Buprenorphine is an FDA-approved medication that helps people with opioid use disorders by reducing cravings and the symptoms of withdrawal. Buprenorphine therapy is an evidence-based practice that increases a person's ability to participate fully in a comprehensive substance use disorder treatment program that may include hospitalization, counseling, case management, medication, and recovery support services. This is the first video in our Buprenorphine Addressing Barriers series. Dr. Randall Brown gives a physician's perspective on medication-assisted treatment with buprenorphine for opioid use disorders.
Things that physicians should know about buprenorphine and reasons I think it's important for physicians to explore getting trained in it is, of course, we are in the midst of an epidemic of opioid addiction and overdose. And in great part, although the lay media would have us believe that that's because the streets are awash in heroin, the vast majority of these complications are due to prescription opioids. And individuals who are using prescription opioids for recreational purposes aren't typically getting them from dealers or the street. About 80% of the time, they're getting them from a friend or a family member, and that individual is getting them from a single prescriber. So it's really incumbent on the medical community to be engaging in practices to ameliorate this epidemic, including, opioid prescription monitoring, and I would argue, given that there is some rate of addiction in the population of chronic pain patients getting opioids, getting their buprenorphine waiver so that they can address that complication effectively when it arises. Buprenorphine is a medication that is used to assist in the recovery of individuals from an opioid use disorder or opioid addiction. It's important that it is accompanied by behavioral treatment or counseling as well. But what buprenorphine does to facilitate recovery is it is an opioid partial agonist. So what does that mean? So it goes to these receptors in our body that naturally respond to opioids, attaches to those receptors, and turns them on. That's what an agonist does. It turns these receptors on. And so full agonists would be heroin, morphine, oxycodone, things like that. Buprenorphine, as I mentioned, is a partial agonist. So what it does is it goes to those receptors, but it only turns them on part way. And that explains why it's a bit safer than full agonists. It's less likely to slow down or stop a person's breathing. It also is a very long-acting medication. When someone's using those other opioids like heroin or oxycodone, those are shorter acting, and someone is often going through cycles where they take one of those opioids and they feel better or normal or maybe even high, and then they're coming off and they feel miserable and in withdrawal, and they're going through these cycles of normal and sick or euphoric and sick throughout the day that make it really difficult to function. Where buprenorphine gets a stable level of this partial agonist that allows them to get away from those cycles of sickness and normalcy and function in an improved way in terms of work, family participation, and issues like that. Buprenorphine helps patients firstly, again, by getting them out of these cycles of withdrawal and normalcy so that they can function in life, again, part of a family and in work, but also actively participate in recovery. If someone is actively intoxicated or in withdrawal, they're not really able to do that in a meaningful way. And so at least as an initial step in recovery, getting on a medication like buprenorphine is a really important part of getting them moving down the road to recovery. And medications like it really seem to be a pretty important part of getting an individual who is addicted to an opioid to a more normal functioning state. Because the withdrawal is so unpleasant and difficult to get through, the relapse rates for opioids in the first 2 months is over 90%. And so we really do think, outside of the fairly limited availability of extended periods of time in a controlled environment, it's pretty difficult for a completely abstinence-based plan without medication-assisted therapy to get someone with opioid addiction from daily use into real recovery. Buprenorphine for detox versus long-term maintenance is an interesting question. Again, there's tension in balancing the desire to get patients to a truly abstinent state where they're participating in recovery and ensuring that their risk for death is reduced. Because once someone has abstained from opioids and they are not on a medication-assisted treatment like methadone or buprenorphine, they start to lose their tolerance for opioid. And that can happen even in a very few days. And then if they return to their customary use after that period of time, they're at significantly increased risk to overdose and die as a result of that use. So while there is this tension around substituting one drug for another and abstinence-based versus medication-assisted treatment modalities, there really is a strong argument in data telling us that medication is really an important first step, if nothing else, just to reduce that risk for mortality. While it is safer in some sense than other opioids, again, because it's a partial agonist, less likely to cause a slowdown or stoppage of breathing and death, it is still a controlled substance and still comes with some risks, particularly if it's combined with other substances that can slow down a person's breathing, like muscle relaxers, tranquilizers, things that physicians call benzodiazepines, or heavy alcohol use. So it's very important that these medications be handled safely. And what does that mean? It means taking them as directed. It means storing them appropriately, which ideally means having them in a locked location. And ideally not leaving home with full medication supplies, but only what you need for the day or for your period of travel. Because again, being controlled substances, there is some risk that you may be victimized for that medication or it may be stolen. So handling it with caution and handling it responsibly is quite important. The most common side effects with both buprenorphine and methadone would initially be nausea or stomach upset. That normally goes away after a period of days taking a regular dose, but if it's severe or intolerable, we're talking to the prescriber about it to see if for a time they might need medications to calm the nausea until they get stable on a dose. These medications can also both cause sleepiness or nodding off, and that may indicate that the dose is too high or that the medication is being combined with something else that's causing that. Again, the most serious side effect with methadone, more commonly than buprenorphine, but can happen, would be as if an extraordinarily high dose is taken and the breathing can slow down and stop and an individual can die. If someone is feeling like they just want to stop taking their buprenorphine or their methadone, I would certainly advise that they work with their physician on that decision, because again, those are both medications that are acting in ways that are similar to heroin or oxycodone in terms of where they go in the body. And so if someone stops those medications immediately, they will again be in horrible withdrawal. And then if they're off those for even a short period of time, at risk for overdose and death if they go back to the substance they were using prior to entering treatment. In treatment agencies that are traditionally abstinence-based, the discussion around the use of medication-assisted treatments can be a bit of a challenge because that abstinence-oriented philosophy may not feel comfortable making room for that. I think the discussion should surround, however, the evidence that supports medication-assisted treatments saving lives. And I think the discussion needs to start there. And hopefully the medication-assisted treatment can be viewed as one of many tools that may fit for part of their population to get them to successful recovery. Buprenorphine and methadone and naltrexone are medications that can be helpful in moving someone toward recovery, but another big part of recovery is breaking patterns of behavior and modifying social networks that went along with regular drug use. And that's where behavioral treatment comes in, and we're working with counselors, and the support of peers in recovery is important for helping the patient reframe major aspects of their lives and how they move from place to place every day.
Stay tuned for the next videos in this series, which will address other barriers that limit use of buprenorphine for treatment opioid use disorders: stigma, concerns about diversion, finding a way to pay for the medication, and lack of physician prescribers.